Good evening to everyone and welcome to today's NEET PG full-scale grant test 1. So there are 200 questions. We have uploaded the ebook. I left the link where you can download the ebook of this today's full-scale grant test containing 200 questions, just like the NEET PG exam. And you solve the paper before you come to the grant test discussion, then you don't feel it is very fast. Identify where you are going wrong at the end of the test and improving those topics. That's all you need to do. Next 50 grant tests every day you attend with Dr. Murli Bharadwaj. Download the ebook from the learnograph.com and solve these 50 tests into 200 questions, 10,000 MCQs, and attend discussion. More than enough. You are going to be the topper. Good to see Ravinder Singh and many more who are all online. Can you please punch the voice loud and clear and or not? And please inform all your friends that the live class of the full-scale grant test discussion every day has started on the YouTube. So, doctor, yes. So first, in the today's paper, let us take up the image-based questions and we progress towards the remaining questions. A 52-year-old with a history of hypertension presents to the emergency department. He complains of the chest pain radiating to the left arm. Physical examination shows a BP of 150/90. So what you are able to see here, lead 2, lead 3, and the inferior leads, AVF, there is a ST segment elevation, which is classical of inferior wall acute MI. And also you are able to see the delta waves. You can see the delta waves. So that is the reason it is a combination. ST segment elevation is a sign of infarction, and delta waves are indication of pre-excitation syndrome like Wolff-Parkinson-White syndrome. So what's for Dr. Which leads in ECG represent the anterior MI V1 to V4. Right ventricular infarction V4R to VR, V6R. And atrial fibrillation, no distinct P waves. So they're all the classical features. A patient with the history of the heart failure is evaluated for the palpitations, irregular pulse, ECG is being performed. And what do you see, doctor, in this ECG? There is an ST depression, which is in the shape of a bubble shape, scoop. So this kind of bubble-shaped ST depressions are the classical thing which is called digitalis effect is what you need to remember. If it is acute MI, there will be ST elevation. Pericarditis, there will be diffuse ST elevation, PR depression, PR segment depression. And in the digitalis, there is this kind of a scoop-like depression. Very classical, frequently asked in the exam. Similarly, tall peak T waves, hyperkalemia. You should not forget. Now, doctor, a patient with a history of arrhythmias, he has been on long-term imidazole therapy. Which ECG changes are expected? typically marked prolongation of the QT interval is one of the important features. What you are seeing here is marked QT prolongation. QT prolongation. Whenever the corrected QT interval is more than 420 milliseconds, you call prolonged QT. And that is a classical feature of the amiodarone. And this prolonged QT, what are you worried? If the QT becomes so prolonged, what are you worried? It can lead to development of polymorphic ventricular tachycardia, which is called torsades de pointes, is what you need to remember. Now, a 57-year-old with history of chronic renal failure. Good to see 13 online classmates. Excellent. Our tribe is becoming big. Please inform all your friends. Dr. Murali Bharadwaj is free on YouTube. But there is a link below this YouTube. You can see there, you can see the learnograph.com. So these 200 questions and the 200 explanatory answers like mind maps, where almost 200 into 5 to 6 high-yield facts are revised. Around 1,000 high-yield facts are being created as an ebook and made available at the learnograph.com. Just by paying $500, you can download the PDF. It's a large sized one, 350 MB, but very high resolution images. Mind maps are a very fast way to do the revision. So totally, I'm going to release 50 full-scale grant tests with discussion in the format of ebooks and freely discuss on the YouTube. 50 into 500 may cost you $25,000, but if you pay $10,000, you will get all these 50 as a package. So most important thing, wherever you took coaching, whatever the apps that you have done, doesn't matter. Taking the mock test, attending the discussion, checking where you are going wrong is very important for you to crack. 100% strike rate will be there if you get motivated to participate in this test and discussion in the next 50 grant tests. So let us continue our discussion, doctor. This 57-year-old with chronic renal failure is brought to the emergency, right? And the BP is 130/80, pulse is irregular, ECG is being performed. So what do you see in this ECG? So given all her history, what is the possibility in a chronic renal failure for you to expect? Typically hypokalemia leading to prolonged QT interval. So QRS and T wave more than 420 milliseconds is called prolonged QT interval, is the key ECG finding in hypokalemia that increase the risk of arrhythmias in the patients who are having chronic renal failure, is what you need to remember. Then a patient presents to the emergency with generalized weakness and palpitations. Potassium level is 9 milliequivalents per liter. Normally potassium is up to 5, 3.5 to 5. ECG is being performed. So what is that you are seeing here? So it is a left bundle branch block. How do you know diagnose left bundle branch block? Widened QRS, widening of the QRS, typically the combination of hyperkalemia and ECG changes, including T wave morphology. The T waves are very tall, and evidence of conduction blocks. That all is in sync with hyperkalemia with left bundle branch block is what you need to remember. Now, doctor, a patient with history of treated right breast cancer with respiratory symptoms, a chest X-ray is being performed. So what do you see here? It is metastatic breast cancer. So breast cancer can metastasize to the lungs and it can appear as well circumscribed masses. Why not TB? TB presents like a cavity. So this X-ray is showing what? Multiple well circumscribed pulmonary masses, which is indicative of metastatic cancer. Even pulmonary abscess will show air fluid levels, which are not there in this X-ray. That's the reason it is a case of metastatic breast cancer. A patient with AIDS presented with non-specific symptoms. Now, a CT scan has been taken. So what are you seeing in this CT scan? Multiple nodules. You are able to see multiple nodules, which typically suggest beyond infectious causes. So whenever a patient is having AIDS, multiple nodules on the CT always raise the suspicion of lymphoma, which is a B cell lymphoma, is what you need to remember. Why not pneumocystis? Pneumocystis will present like a diffuse interstitial infiltrates rather than nodular lesions. That's how you differentiate. A patient with long history of smoking presents with a progressive dyspnea, cough, and radiograph is being done. So what is your diagnosis? So what do you see here? The diaphragm is completely depressed. There is a vertically oriented heart and there is a overinflated lungs. There is a loss of normal vasculature. It is all indicative of emphysema, barrel-shaped chest. That is what you need to remember. So that's the reason the correct answer is emphysema. So once more you get ditto, similar kind of questions, doctor. So 50 full-scale grant tests you practice with Dr. Murali Bharadwaj. I know the examiner's mind. I know what he is expecting from you. It's not about a lot of knowledge to become a topper in NEET PG. It is all about knowing what examiner wants. If you have that, if you practice the right content that I will provide you in the form of 50 ebooks that you can download, each mock test is 260 pages ebook with explanations, with high-yield facts in the form of mind maps. You are going to make it. Solve the paper. Keep a timer. Sit every day morning, 2-3 hours you spend. Solve the paper. Evening, attend the discussion. And every day I upload one new full-scale mock test booklet. Now, a patient presents with complaints of dyspnea, decreased breath sounds on the right side, chest X-ray followed by CT is being done. What is your answer, doctor? This is called bullous emphysema. What you are seeing here is a bulla. So bullous emphysema is what you are able to see in this given CT is what you need to remember. A patient with a history of chronic lung disease presents with cough and weight loss. Initial workup shows chest X-ray and also the CT scan has been done. So what is it most likely to be? It is likely to be a typical mycobacteria, chronic lung disease patient with cough and weight loss. So typically it shows cavities and nodules is the classical presenting finding. So chest X-ray is showing what? Typically, apical opacity suggestive of with a lucency in the apical cavity. Initially, we thought it as what? TB, but cultures are negative for Mycobacterium tuberculosis. CT has got a peripheral opacity with a small lucent center. Here you can see, and which is all typically the feature of atypical mycobacterial infection. A patient has got a history of travel to a rural farming area where there are dogs, there are pigs, there are sheep, there are goat. He also has eosinophilia. Decreased breath sounds on the left side. And imaging has been done. So what you're able to see? Water lily sign in the hydatid cyst is what you're able to see, the floating membranes of the hydatid cyst. So there is a solid tissue layering. A layer of tissue is what you're able to see, the water lily sign in hydatid cyst. A patient presents with symptoms of numbness, tingling, episodes of blurred vision, transient episodes of similar kind of clinical features were there in the past. That means the lesions which are separated by time, separated in geography, and multiple lesions. So what do you see here, doctor? Typically in the corpus callosal area, you are able to see the opacities which are called Dawson's fingers. What are they called? Dawson's fingers, which is because the demyelination caused by multiple sclerosis is what you need to remember. So if it is migraine with aura, there will be transient visual and sensory disturbances. MRI will not show Dawson. If it is vitamin B12, typically there will be neurological symptoms, but spinal cord involvement, subacute combined degeneration of the spinal cord will be there. So that is what you need to remember. A patient presents with hyperextensible skin and joint hypermobility with the history of easy bruising. And on examination, what is this physical sign, doctor? Typically, the Gorlin sign, where there is an ability to touch the tip of the nose with the tongue, which is seen in Ehlers-Danlos, is what you need to remember. A patient has multiple cutaneous nodules on the trunk. And on examination, characteristic physical sign. What is this sign? This is called buttonhole sign. So in neurofibromatosis type 1, where a neurofibroma you can be able to depress with a fingertip pressure, which is called buttonhole sign, is a feature of neurofibromatosis type 1. A skin biopsy was done in a patient with history of erythematous plaque, silvery scales. What are you seeing here in this histological picture? You can be able to see the pustule of Kogos, which is the histopathological hallmark of psoriasis, where there will be a subcorneal collection of the neutrophils. And those silvery scales is a very important indication of the psoriasis is what you need to remember. A 12-year-old boy with hypopigmented scaly patches on his face. Everybody, all his class girls are saying, hey, this boy has some problem. So he comes and says, Mama, all my classmates are saying I have these white patches. Is it leprosy? No, it is classically pityriasis. Loads and loads and loads of puberty, and that lead to oval-shaped patches with fine scaling. Then what will Mama say? Don't worry, my boy, as you're going to become a very promising, handsome young man who is going to get the seat in NEET UG to become a doctor, don't worry, it will all regress, is what you need to remember. So what are the other hypopigmented lesions, Dr. Vitiligo? Vitiligo is autoimmune, destruction of the melanocytes, typically well-defined and devoid of scaling, but here there is scaling. Atopic dermatitis, there will be pruritic erythematous patches with excoriation, lichenification. Tinea versicolor, it will be both hypo plus hyperpigmented. Hypo plus hyperpigmented patches with fine scaling. Often on the trunk is what you typically see, is what you need to remember. So, doctor, today only go to learnograph.com. In this, you will find a test one, full-scale mock test, 200 MCQs, first as a question paper. Put a timer, sit and solve 200 with one of your friends, right? It is a downloadable PDF that I provide. So pay $500 to download it. 2-3 friends also can share it, no problem. So after that, you go through the mind maps on explanatory answers on every question, and I will add around 5 to 10 important high yield facts. So like this, I will give you totally 50 full-scale grand tests in the next 70-80 days before the NEET PG, and also discuss it free on the YouTube. A 5-year-old boy presents with itchy, inflamed skin on the face. There are Dennis Morgan folds. Where do you see Dennis Morgan folds? We see that extra skin of the folds that appear under the eyelids in individuals with chronic inflammation because of the chronic rubbing and scratching. Typically, atopic dermatitis is what you need to remember. So 25-year-old male with patchy hair loss on the scalp, and you found, what are these called? Exclamation mark. It's called exclamation mark sign. Hairs look like exclamation mark, which are indicative of alopecia areata, is what you need to remember. So why not telogen effluvium? It typically happens whenever there is a lot of stress, illness, hormonal changes. Why not tinea cavities? There will be scaling. And sometimes black dots representing broken hairs, black dots are the characteristic feature. Androgenetic alopecia, it is most common cause of hair loss with gradual thinning of the hair on the scalp. 30-year-old female has got these skin lesions. What are they, doctor? Target lesions. Typically seen in erythema multiforme. Typically a hypersensitivity reaction with target-like lesion with central dark areas is erythema multiforme. Why not erythema nodosum? Nodosum means inflammation of fat tissue, that is paniculitis, is called erythema nodosum. So painful erythematous nodules typically on the shin, seen in infections, medications, etc. One of the full-scale mock tests, I will give an image-based question on nodosum also, is what you need to remember. Then a 5-year-old child presents to the pediatrician's office with a rash on his face. He is feeling unwell. He had fever for the past few days. Upon further questioning, several children in his daycare have been sick. What is this? Slapped cheek appearance, which is seen in erythema infectiosum, is what you need to remember. Whereas scarlet fever, group A streptococcus presents with fever, sore throat. It's called sandpaper-like rash, texture of the rash in scarlet fever. Why not measles? Measles has got fever, coryza, cough, conjunctivitis, and a macular papular rash that starts on the face and spreads downwards. So they are all the image-based questions, doctor. In the today's full-scale mock test. Now let us start with all the remaining 180 critical minute-based questions. Yes, I hope you all have downloaded the question paper from the learnograph.com. Once you go there, you pay $500. You can download the PDF, take the mock test before coming to the discussion, and next 50 mock tests I'm going to make you the topper. So Ayesha Ahmed is saying, sir, please give INI-CET oriented tests also. This is both NEET PG, INI-CET, both of them covered. These have got the high-yield topics from both of them, and also clinical minute-based questions, doctor. No worries at all. Now, doctor, let us start. 68-year-old male with a history of non-valvular atrial fibrillation with creatinine 2.3. So whenever there is any renal dysfunction, especially, apixaban, which is the direct factor 10A inhibitor, factor 10A inhibitor is the one which you typically prescribe. So now, a 55-year-old with a history of diabetes presents to the emergency with a rapidly progressing foul-smelling wound on his left foot. There are a lot of anaerobic bacteria. One minute, doctor. Anaerobic bacteria. Which class of antibiotics is ineffective in treating anaerobic bacteria? Aminoglycosides. So aminoglycosides are ineffective against the anaerobic bacteria because they lack the required oxidative mechanism for the antibiotic uptake into the bacterial cells. So that's the reason aminoglycosides are useless, unlike metronidazole, etc., which we use for anaerobic bacteria. 47-year-old woman undergoes the routine colonoscopy as a part of the health checkup. So she reports a long history of constipation, for which she regularly uses the over-the-counter laxatives. So during the procedure, the gastroenterologist notes that the lining of the colon is darkly pigmented. So which laxative is known to lead to this kind of pigmentation? Senna is an anthraquinone containing laxative known to lead to melanosis coli, is what you need to remember. So Senna, anthraquinone laxative, and sorbitol, osmotic laxative, can cause abdominal cramping. Max sulfate is also osmotic laxative used for the constipation relief. Bisacodyl is a stimulant laxative that promotes the bowel movements, is what you need to remember. There is a case of 68-year-old with weight loss, anemia, early satiety. Endoscopy shows a malignancy in the stomach. What is it most likely? The most common is the gastric adenocarcinoma, which is the epithelial tumor of the stomach, whereas carcinoid is neuroendocrine cells, and just gastrointestinal stromal tumor arises from the interstitial cells of Cajal, which are mesenchymal cells, is what you need to remember. So, a patient is admitted to the emergency in a state of shock after a severe car accident. The medical team is closely monitoring. So, what is the renal response to the shock? Typically, shock will cause a decreased renal perfusion. There's a systemic response to preserve the blood flow to the vital organs, and that leads to decrease in the renal blood flow as part of the body's effort to conserve the resources, is what you need to remember. After receiving a blood transfusion, a 54-year-old developed tachypnea. After how many hours transfusion-related acute lung injury typically occurs? 6 hours. Typically after 6 hours, trolley typically happens, and there will be pulmonary cackles, bilateral pulmonary edema without any signs of congestive failure, indicating it is a non-cardiogenic pulmonary edema, is what you need to remember. So you should be very sure. Taco versus trolley, one of the favorite MCQs of the examiner. Now, doctor, a 5-year-old with self-mutilating behavior, development delay, signs of gout, hyperuricemia. What are we talking here? We are talking Lesch-Kanihan syndrome. Lesch-Kanihan is a deficiency of HGTRT, hypoxanthine guanine phosphoribosyl transferase, is the Lesch-Kanihan. So, where is it involved? In the purine salvage pathway. So, there is a recycling of the purines. You require HGPRT. And if they are not recycled, they get metabolized to form the uric acid production. And it is a X-linked inheritance, is what you need to remember. 1 minute, doctor. I have a call from the hospital. Yeah. So Lesch-Kanihan is a X-linked resistant inheritance, is what you need to remember. So now, doctor, during a pediatric ophthalmology, they focus on conjunctivitis in neonates. What is it? Because of Neisseria gonorrhea lead to ophthalmia neonatarum, is what you need to remember. And that's the reason to prevent gonococcal and chlamydial infections in newborns. We do prophylaxis before birth. Now, chlamydia, it causes neonatal conjunctivitis, but less severe than Neisseria, but chlamydia can also lead to pneumonia. Now, during a well-child visit, Which one among the fontanelle is last to close? Anterior. Anterior fontanelle typically closes by 18 to 24 months of age. Posterior fontanelle by 2 to 3 months of age is what you need to remember. Which test is most rapid and sensitive to detect the capsular antigen of Cryptococcus? Latex agglutination is the most rapid and sensitive test for detecting the polysaccharide capsular antigen in Cryptococcus neoformans. Right? So now, which medium is used for selective cultivation and differentiation of the Candida species based on the colony color? The name itself says chrome agar candida is a selective chromogenic culture media. So everything about Candida you need to know, doctor. The most common fungal infection in the immunocompromised and neutropenic patients, and germ tube formation occur at 37 degrees, which is called Reynolds broad phenomena. It forms pseudo hyphae in culture at 20 degrees. It is yeast-like fungus, and it is identified by true hyphae and chlamydospores. That is what you need to remember. Now, the next question. At what age a person is legally capable of giving consent for the surgery according to section 87? So you should be very sure. 18 years. 18 years. So certain sections, definitely 2 MCQs will come in the NEET PG exam on the various criminal procedural code and sections. Section 87, above 18, one can give consent to suffer harm from acts not intended to cause the death or grievous hurt, including consent for surgery. Section 89, consent for physical examination, minimum age is 12 years. Section 90, consent under influence, insanity, intoxication is invalid consent. Section 92, implied consent. In emergency situation, consent is not required according to Section 92. 31-year-old, today history of blisters, brownish urine after a trip to Jaipur in April, small blistering episodes in the past, vesicles, bullae on the face, dorsal hands, forearms. Typically, it is uroporphyrinogen 3 decarboxylase deficiency, which lead to porphyria cutanea tarda. Take it as my word, doctor. Wow, that's good. We are becoming very popular. 19 online classmates. Very good, doctor. हम बहुत खुश हैं. Dr. Murli Bharadwaj is absolutely free for you on the YouTube. But you have a link, learnograph.com below this YouTube video. Just go click it. You have this full-scale grant test, 200 questions, along with 260 pages of notes in the form of mind maps with around 1,000 high-yield facts, fully available for every mock test as an ebook on the learnograph.com. Today only you download it. And also, I'm going to launch 50 full-scale grant tests in the next 60 days and conduct a discussion free on the YouTube. Okay, doctor? Now, continuing our journey, you should know everything, anything about porphyrias. Sure, short आने वाला topic है. Consider my word to you. One question definite. Now, doctor. Uroporphyrinogen 3 decarboxylase. The defect causes porphyria tarda, leading to photosensitivity, blistering, dark urine, etc. Aminolevulanic acid dehydratase, abdominal pain, gastrointestinal upset, polyneuropathy, defect in ALA dehydratase. Uroporphyrinogen 3 synthase, congenital erythropoietic porphyria, dark urine presence in childhood. Porphobilinogen deaminase, acute intermittent porphyria. It does not lead to dermatological manifestations. It involves abdominal pain. Aminolevulanic acid synthase. It leads to X-linked sideroblastic anemia. Symptoms of anemia: no dermat, no urinary manifestations. That's what you need to remember. So what substance is elevated in each of these conditions? What is the enzyme involved is the favorite question. Uroporphyrinogen 3 is increased in porphyria cutaneous tarda. Protoporphyrin is elevated in erythropoietic protoporphyria. Porphobilinogen is increased in acute intermittent porphyria. Delta aminolevulanic acid is increased in lead poisoning, acute intermittent porphyria. And bilirubin typically is a part of the heme degradation pathway ultimately leads to. So one question will come on the porphyrias, doctor. 63-year-old with aortic valve disease, 3 weeks of fatigue, systolic murmur, tender, erythematous nodules on the finger pads. Blood culture show alpha hemolytic gram-positive cocci, which is catalase negative optocin resistant. Oh my God. One MCQ sure shot in every NEET PG. Take it as my word. Viridon streptococci. So this classification, you need to remember it like anything, doctor. Alpha hemolytic optocin resistant catalase negative, part of normal oral flora with dental caries, subacute endocarditis, viridon streptococci. Catalase positive, beta hemolytic, most common cause of infective endocarditis is aureus. Catalase negative, beta hemolytic, causing tonsillitis, scarlet fevers, rheumatic fever, 5 genes. Beta hemolytic or gamma hemolytic, galolyticus. Optocin sensitive, uncommon cause of infective endocarditis is pneumonia. Catalase positive, non-hemolytic, but common in infective endocarditis with foreign body insertion is staph epidermidis. That is what you need to remember. Now, the next question. 7-year-old girl with 6 months history of irritability, lethargy, subconjunctival pallor, hemoglobin 9.2, wet stool mount shows fertilized pregnant egg, fertilized egg, 2 to 8 cell stage. It is classical of Nicator americanus is what you need to remember. Nicator americanus is the hookworm that leads to chronic loss, blood loss, iron deficiency. Transparent fertilized egg, 2 to 8 cells is Nicator. Ascaris lumbricoides lead to ascariasis. Egg is knobs. Doorknob is there, no doctor. Knobby coated round appearance. Enterobius vermicularis is pinworm. Nocturnal perianal pruritus will be there. Tape test. Apply a tape. Eggs are stick to that. Eggs are ovoid. Slightly flattened on both sides. Diphyllobothrum latum is fish tape form leading to vitamin B12 deficiency. Trichuris trichura can lead to iron deficiency in children. Eggs are barrel-shaped. Bipolar plex. Tinea solium. Intestinal teniasis in neurocystic causes from undercooked pig. Pork is what you need to remember. Here the eggs are round with the striated outer zone. That's how you need to remember. Anda bechna hai kalke NEET PG mein, you need to know the eggs. 26-year-old amenorrhea, 6 months after discontinuing low dose oral contraceptive pill. What do you want to do? You need to evaluate for amenorrhea. So when do you want to evaluate? If the duration, amenorrhea lasting 3 to 5 months post OCP discontinuation is typical. But beyond 5 months post discontinuation, if there is amenorrhea, you need to evaluate the amenorrhea, is what you need to remember. Now, 28-year-old primary gravida had 39 weeks gestation in labor for 22 hours, cervix dilated, 80% effaced, membranes have spontaneously ruptured 2 hours ago. What is the most appropriate step? You should know everything, anything about all this labor dysfunction. What she's having is a prolonged, latent phase of the labor, where there's an extended duration of the labor with a very minimal cervical dilatation progress, where the cervix is favorable for delivery and membranes have ruptured spontaneously, and augmentation of the labor with intravenous oxytocin is the one which is required to stimulate the uterine contractions and enable the progress of the labor. So, doctor, I leave the literature for you. Today only, go to learnograph.com. Every day, one full-scale grand test, 200 MCQs. I upload the ebook, pay $500 and download the ebook. Practice the questions, sitting with a friend. Go through all the mind maps, high yield facts, get ready for the exam. If you solve this 50 full-scale grand tests, ebooks more than enough. You don't need anything else. This is the mother of everything. Latent phase, early stage of labor from onset to the cervix dilatation to 4 centimeters. Prolonged means extends beyond 20 hours in nullipara and 14 hours in multipara. For that, rest and labor augmentation. Labor augmentation is with oxytocin infusion and artificial rupture of membranes. So before you do oxytocin, there should be favorable cervix, no spontaneous labor progression. Continuous fetal monitoring, you need to basically do. Patient presents with fatigue, arthralgia, renal disease, palpable porphyria, low complement. What is your diagnosis, doctor? Mixed cryoglobulonemic syndrome is the diagnosis. So yes, fatigue, arthralgia, renal disease, palpable porphyria, low complement level, positive rheumatoid factor. Very important. Chronic HCV, systemic lupus can be associated. Serum cryoglobulin, skin and renal biopsy. First, underlying cause like HCV, SLE, they need to be controlled before the mixed cryoglobulinemia comes to a conclusion. And where do you get type 1 cryoglobulinemia? It is associated with multiple myeloma. Multiple myeloma is what you need to remember. So mixed cryoglobulonemic syndrome is associated with HCV, HIV and lupus. Once more, doctor, every NEET PG, one question comes from vasculitis, 100% choose short topic, which you cannot miss. Now, doctor, a 5-year-old boy is brought to the left hip pain. He woke up in the morning with a limp and says that his left hip hurts. He has a recent upper respiratory infection. But that is the clue. That is the most important diagnosis, is transient synovitis. Typically seen in children 3 to 8, post-viral hip pain and limp. Only mildly elevated WBC, ESR and CR. And it is conservatively managed with the NSI like ibuprofen and full recovery within 1 to 4 weeks. So ibuprofen and close follow-up is the management for transient synovitis. 62-year-old women presents with acute leg pain following an exercise. Typically, she experiences pain at the right knee, posture cuff while walking. There's a tenderness on the medial head of the gastrocnemius with a chymosis in medial malleolus, classical of a ruptured popliteal cyst. Typically, it causes pain and swelling post-exercise, and it is called crescent sign ecchymosis. Why not anserine bursitis? The pain on the medial side of the knee exacerbated by movement or pressure. Why not stress fracture of tibia? Typically, there is a tenderness on the shin, not sudden swelling. Why not tear of the medial collateral ligament? Typically, there is a medial knee tenderness and joint laxity. Why not medial meniscus tear? Typically, it is a twisting force, presence with knee effusion, locking, catching, etc., is what you need to remember. Now, doctor, a 40-year-old woman is brought to the emergency after a low-speed vehicle accident. There's a decreased sensation in the anterior medial side of the right thigh, decreased knee extension, and patellar reflex. So what is it pointing? All that is pointing to the femoral nerve. So decreased sensation in the anteromedial thigh, femoral nerve. Patellar reflex reduced, femoral nerve, is what you need to remember. If it is common peroneal nerve, it leads to foot drop, dorsolateral foot and posterolateral leg. Ilioinguinal nerve in the upper medial thigh and groin pain. Obturator nerve innervates medial thigh and injury can cause weakness in hip adduction. Tibial nerve, it innervates the posterior compartment of the leg and injury affects the plantar flexion. So you have to be 100% sure. These are the very, very, very important topics in NEET PG. NEET PG. Be with Dr. Murali Bharadwaj. Today only go to learnograph.com. Right? So here you can download the PDF by paying $500 for every ebook on the mock tests and attend in the evening for a live discussion after solving the paper. A 16-year-old boy comes to the office due to the right knee swelling after a soccer practice. Occasional flu-like illness, large effusion, decreased range of motion in the right knee, yellow translucent fluid, aspirate, leukocytosis. So Lyme disease, Borrelia burgdorferi, migratory arthralgia, acute monoarticular arthritis, summer spent in an endemic area. They all suggest Lyme disease. Oral doxycycline is the treatment of choice. A 26-year-old woman at 35 weeks of gestation comes to the labor with painful contraction, 7 centimeter dilated, 100% effaced, fetal head at +2 station. She has bright red amniotic fluid. Her sinusoidal fetal heart rate pattern. So what is the most likely possibility? Typically, there is a vasopressia, fetal blood loss. It required urgent cesarean section is what you need to remember. So fetal blood loss lead to sinusoidal heart rate pattern. Intraamniotic infection lead to fetal tachycardia. Oligohydramnios can lead to variable deceleration due to umbilical cord compression. Cord compression lead to variable deceleration. Preterm gestation increase fetal heart rate baseline, reduce variability, lower amplitude accelerations. That is what you need to remember. Which procedure objectively determines the refractive error of the eye? Retinoscopy. Retinoscopy. So everything, anything you should know, doctor. Gonioscopy, angle of the anterior chamber. Patchmetry, thickness of the cornea, keratometry, curvature of the cornea, campimetry, field of vision, specular microscope, you want to know the corneal endothelial reserve, specular microscope, confocal microscope to study the corneal layers, especially in acanthamoeba keratitis. Similarly, tonography, outflow of the aqueous humor, OCT and HRT, optical coherence tomography and Heidelberg retina tomogram, studying the retinal nerve fiber layers useful in glaucoma and macular pathology. Placidus disc, it assesses the corneal topography and corneal surface irregularity is what you need to remember. So today only visit learnograph.com, doctor. There I uploaded 150 mind maps ebook. Mind maps ebook in ophthalmology. It costs you only $400. You can download this ebook and you have around 1500 high yield facts in this. Just master them for a quick revision. So the patient presents with euvolemic hyponatremia. 73-year-old with a history of COPD after initiating thiazide diuretics for hypertension presents with confusion, lethargy. He has a major depressive disorder treated with sertraline and he is normotensive. His sodium is 121, potassium 4.2, serum osmolarity 255, urine osmolarity 520. Urine sodium is increased. What is the likely cause? Yesterday also we discussed SIADH. So sertraline and thiazide diuretics can exacerbate or lead to SIADH and hyponatremia. Every day I see 60 to 70 elderly people. Telma, thiazide diuretic we often use. Sertraline we give. SSRIs. They all lead to hyponatremia. The hyponatremia of SIADH is euvolemic hyponatremia, no pedal edema, no congestive heart failure, no hypothyroidism, no cirrhosis of liver, with a normal liver, normal lung, normal heart, normal thyroid. In a euvolemic individual, hyponatremia is SIADH is what you need to remember. 73-year-old with a history of depression treated with SSRI. Once more. It is syndrome of inappropriate ADH secretion. Now, doctor. An immunocompromised patient present with systemic symptoms. Lung nodules, brain abscess, gram-positive acid-fast filamentous bacteria on the culture. There is a pulmonary endocardiosis. What is the treatment of choice? Oriconazole. Oriconazole is what you need to remember. Estrianom is ineffective against gram-positive. Trimethoprim sulfamethoxazole plus carbapinum, typically given for CNS. Gram-positive acid-fast filamentous bacteria is an important clue to say it is nocardia, is what you need to remember. So whenever CNS involvement is there, add carbapinums. The mainstay is trimethoprim sulfamethoxazole. Antifungal is for aspergillosis, is what you need to remember. A patient has advanced age, CD4 count only less than 50. Diarrhea, blood culture growth, non-tuberculous mycobacteria. What is the treatment, doctor? Typically, macrolide-based therapy with ethambutol is the treatment for mycobacterium. Avium complex is what you need to remember. So once more, doctor, everything, anything you should know about the MAC. So now, a patient has history of ankle pain, acute onset. Risk factors are heavy alcohol use and diuretic use. What is he experiencing? So heavy alcohol use, diuretic use, acute ankle pain, rapid progression, maximum intensity in 12 to 24 hours, synovial fluid if it shows needle shape negatively, birefringent durate crystals, then it is gout with acute monoarticular arthritis. Actually, here the option should be gout. It's little missing here. Now, a patient with 50-year-old with smoking history with recurrent pneumonia in the same lung, suspected to have localized airway obstruction. What is the possibility? We need to do CT scan of the chest. Over the 50 smoker recurrent pneumonia in the same lung, think of malignancy. CT scan of the chest is the best way to identify. A patient has smoke with presence with fatigue, arthralgia, renal disease, palpable purpura or vasculitic purpura, impalpable purpura or thrombocytopenic purpura. You should not forget. Low complement levels. What is your diagnosis, doctor? Mixed cryoglobulonemic syndrome. Just now we discussed it. A patient has flank pain, hypertension, history of hematuria, bilateral abdominal mass, and a family history of kidney disease. Oh my God. This is classical of autosomal dominant polycystic kidney disease where flank pain, hypertension, history of hematuria, etc., etc. So everything, anything you should know, doctor. You prefer antihypertensive therapy with ACE inhibitors, ESRD will occur. You need to manage with hemodialysis or transplant. Now, doctor, a patient with anterior mediastinal mass, pruritus, alcohol-associated pain, elevated lactate dehydrogenase, and dysnophilia. What is your diagnosis? So tell me, doctor, what are the 4 T's you remember about anterior mediastinal mass? T for thymoma, T for teratoma, T for retrosternal thyroid. Retrosternal thyroid with goiter is anterior mediastinal mass. T for terrible lymphoma, Hodgkin's lymphoma. So anterior mediastinal mass, pruritus, alcohol pain, elevated LDH, dysnophilia, more than 60 years age, and read Steenberg cells, alcohol-induced pain, B symptoms like fever, sweat, and weight loss. Think of Hodgkin's lymphoma. Every NEET PG has what? Lymphoma, lymphoma, lymphoma. You have to be very good. One question on leukemia, one question on lymphoma. Without that, अगर NEET PG है तो मेरा नाम मुरली भरद्वाज नहीं है. A patient presents with mononucleosis like illness, fever, malaise, fatigue, absolute lymphocytosis with atypical lymphocytes. CMV, IgM serology is positive. What is the most likely diagnosis? Cytomegalovirus infectious mononucleosis. First of all, there is a mononucleosis-like illness, absolute lymphocytosis, milder pharyngitis, splenomegaly, lymphadenopathy, negative heterophile antibody testing, positive CMV serology. That is how you identify. And antiviral valganciclovir is the treatment of choice for the CMV infection, is what you need to remember. Now, doctor, the next question. A patient with AIDS presents with odynophagia, visible oral thrush. He has not improved with empiric fluconazole treatment. Large linear ulcers, that itself is a clue. Odynophagia, oral thrush, linear ulcers, intranuclear and intracytoplasmic inclusions, no response to the empirical fluconazole. Think about CMV esophagitis. Intravenous ganciclovir is the treatment for CMV esophagitis. Whereas why not herpes? Herpes esophagitis will show small, round, ovoid ulcers. CMV esophagitis, linear ulcers in the esophagus. So you need to be very good doctor. Candidal esophagitis, generally it responds to fluconazole. Aphthous ulcers respond to topical steroids. Pneumocystis pneumonia is treated with pentamidine or trimethoprim sulfamethoxazole. A patient experiences midline, lower abdominal pain radiating to back and thighs, starting 1 to 2 days before menses. Especially with nausea, vomiting, diarrhea, no chronic pelvic pain, pelvic examination normal, think of primary dysmenorrhea. The pain is radiating to the back and thighs. Symptoms begin 1 to 2 days before the menses, very important. And it is the prostaglandins which are released responsible for all the pain and systemic symptoms. So how do you treat, doctor? NSAIDs are the ones which are the treatment. So that is the reason you should know ovarian torsion pain, unilateral and acute. Mittelschmerz occurs at ovulation, not before menstruation. Endometriosis, abnormal uterine bleeding, cervical motion tenderness, they all will be there in the history. A postpartum patient presents with a temperature of 37.9 at 8 hours post-delivery chills, a firm contracted uterus, normal lochia. What is the management? It is a routine postpartum. Temperature slightly elevated, chills, contracted uterus, normal lochia, changes occurring within 8 hours post-delivery. Just you need to continue. So you need to know what are the physiological postpartum symptoms? Mild hyperthermia, low-grade fever, transient rigors and chills, breast engorgement. They're all very routine. You should know what are the routine and how to know what are the complications. Complications. Suppose if the uterus is tender, abnormal discharge, poor contraction, then it is complicated. If the temperature is more than 38 after 24 hours, it can indicate infection. So you should know how to differentiate normal from abnormal. Normal from abnormal whenever there is puerperal patient. So what is the measure of dispersion? Which measure of dispersion is the ratio of the standard deviation to the mean of the observations expressed as a percentage? It's called coefficient of variation. It's a standardized measure of dispersion of a probability distribution. And it is very useful because it allows the comparison of the relative variability between the two data sets based upon the two different mean values is what you need to remember. So I leave the literature for you. What is variance, what is mean deviation, what is coefficient of variation, what is standard deviation, what are quantiles, what is the range. So today only go to the learnograph.com to download Dr. Which statistical method is used for estimating the survival functions in medical research, accounting for right censored data? भैया right censored data क्या होता है? Right censored data. So you should know that there are two things, doctor. Right censored data occur when a patient withdraws from a study before the final outcome is observed. Kaplan-Meier survival curve is a special tool where it estimates the survival function from the lifetime data, and the advantage of it over that of the bland Altman plot is it handles the right censored data. So there are the two ways by which survival statistics are done. If you want to determine the number needed to treat in order to prevent one additional adverse effect, what do you depend on? Absolute risk reduction. The number needed to treat is the reciprocal of absolute risk reduction, 1 by ARR. This will help to determine how many patients need to be treated with a particular therapy to prevent one additional adverse effect, which is very crucial to know the effectiveness of treatment. So you should know odds ratio odds of a disease in exposed group to odds in non-exposed. It is the preferred measure in case control studies. A by C by B by D, AD by BC is called odds ratio. Attributable risk is a difference in the disease rate between exposed and non-exposed. It indicates the proportion of the disease occurrence due to the exposure. Absolute risk reduction is the reduction in the risk with the treatment compared to placebo. The number needed to treat NNT is 1 by ARR. The number needed to harm is 1 by AR. 1 by attributable risk will give you the number needed to harm, NNH, is what you need to remember. So, doctor, a patient with SLE presents for evaluation. What do you see classically in SLE? SLE is an autoimmune condition, immune complex disorder. So, complement C3, C4 levels are typically decreased. There's a lymphopenia, anemia, very typically in SLE is what you need to understand. Now, doctor, a patient with chronic hepatitis C previously treated with interferon alpha is now experiencing fatigue, jaundice. CBP shows anemia. Which drug lead to hemolytic anemia in a hepatitis C patient? Ribavirin causes hemolytic anemia because it accumulates in the RBCs. Interferon alpha can cause anemia, but not typically hemolytic anemia. Ribavirin impedes the GMP synthesis. That is the main mechanism. GMP, guanosine monophosphate synthesis, that affects the viral replication. At the same time, it also will affect the red blood cell stability, hence lead to development of hemolytic anemia. A young patient with Down syndrome, with fatigue, with pallor, with petechiae, with hepatosplenomegaly, Downs is a risk factor for ALL. Which type of ALL? B cell type of ALL is very common in the Down syndrome. So, for the brevity of time, doctor, my job is basically to stimulate you to prepare. A lot of us, what we do? We pay money, we buy a subscription in the app will offer mock tests. We think we will take time after becoming perfect, we will take the mock test. कुछ भी नहीं होता, एग्जाम हो जाता, रिजल्ट भी निकल जाता. But with Murali Bharadwaj, I give you in the format of ebook. Initially question paper, then the 200 explanations in the form of mind maps with around 1000 high-yield facts in the format of ebook. Just you download the ebook by paying $500 on learnograph.com. Sit with your friend, solve the paper, evening come to discussion. हम at least 70-80 questions discuss करेंगे मिलके, ताकि आपको इंस्पिरेशन रहेगा कि भाई पूरा 200 क्वेश्चंस का मॉक टेस्ट लेना है, क्योंकि डॉक्टर मुरली भारद्वाज मेरे साथ शाम को, even if I become late in the hospital, you are my greatest priority of life. Of course, patients are also my priority. Even if it is late, even if I'm tired, if I handled about a half a dozen of myocardial infarctions, doesn't matter. My heart is really with you. To hold your hand, to become your classmate, roommate, benchmate, tablemate every day, and inspire you to prepare. All right, doctor. So with that, we will take a break for today. Just go down, learnograph.com, click it, download, and enjoy taking the tests every day and studying with Dr. Murali Bharadwaj. Good night, and be in high spirits, because what is after all the life? Life tomorrow when you become consultant is miserable. What is happiest part? Preparing for entrance to become MD before you become consultant, right? So enjoy the best part of your life today with Dr. Murali Bharadwaj every day. Good night.